You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This is episode 111. This is a divine number for me, as I'm sure is for many listeners. If not, look it up. It's sort of a divine number. It's incredible to have on the show with me someone who I consider a dear friend. He is tour de force, extremely well published, terrific clinician, super well trained, a great colleague and friend. I call him Saras. So Saras, welcome on the show. Welcome to Parallax. And Saras is here with us. He's going to wrap up ACC 24 for us, a highly action-packed meeting in cardiology. Terrific trials were presented, terrific science was presented. Some practice-changing science was presented, in my opinion. And we're going to discuss 5 trials that Saras has picked for us, which he thinks are important in the context of how we manage our patients in cardiovascular medicine. So with that introduction, Saras, thank you so much for doing this for us. This is a divine episode, 111. Welcome on the show.
Hi, Ankur. Thank you for having me. Truly appreciate the opportunity to share some time with you and your listening audience. Thanks for the opportunity. So as you know, I'm an interventional and a critical care cardiologist. So that's my bias. I pick trials that we see relevant to patients we see in our practice, both in the outpatient setting, the cardiac cath lab, or in the cardiac ICU when they're extremely sick. So we will start with the first one. The one that I really want to discuss is called Danger Shock. So Danger Shock, as you know, Ankur, was a study that was many years in the making. This is a trial looking at use of a microaxial percutaneous left ventricular assist device, commonly known as the impeller pump, in patients with STEMI complicated by cardiogenic shock. This was been in the making for slightly over 10 years now. Initially started as a Danish shock trial and then included Germany and became Danger Shock. Eventually included some sites from the United Kingdom. About 355 patients that they screened with STEMI and cardiogenic shock. Cardiogenic shock was largely defined as low blood pressure, hypoperfusion, need for vasopressor support, and low LV function less than 45%. And in these patients, they excluded many things: mechanical complications, severe aortic valve disease, peripheral arterial disease, which would impede the large bore access for the circulatory support. But most importantly, in my opinion, they excluded patients with comatose out-of-hospital cardiac arrest, which has been the Achilles heel of shock trials thus far. So this is a very appropriate exclusion. After that, they randomized patients with STEMI and cardiogenic shock into those with and without the need for impeller assistance. And they performed standard of care techniques for PCI, did culprit vessel PCI only, and then staged the non-culprit disease during the same hospitalization or subsequently soon after as per contemporary practice. In this trial, they randomized of the patients they randomized, mean arterial lactate was 4.5, so they were quite sick. Mean EF was 25%. 20% were resuscitated. So 20% were resuscitated non-comatose out of hospital arrest. And largely, about 72% were anterior MI, which, as you know, is the sickest subgroup of those presenting with STEMI. And nearly half was stage C cardiogenic shock, a quarter was stage D, and a sixth was stage E. So quite a sick spectrum of the population. They took these patients and 96% received PCI. Very importantly, nearly 50% of them had an impeller placed pre-PCI, which is a paradigm that many of us who work in the shock space have been asking for or advocating for passionately to improve the ventricular function prior to opening up the artery. I'm going to pause here before I share the results and see what comments or guidance you have for me, and then we'll keep going.
Yeah, no, thanks, Saras. Thanks for putting this into context. I agree with you that this is arguably the most vexing patient population that we care for as interventionalists. And acute myocardial infarction complicated by cardiogenic shock, as you know, and have published, has remained stable, unfortunately, with a mortality of 50% across the spectrum of all the advancements which have been made in primary PCI. So certainly a patient population that merits research and attention. And the microaxial flow pump, or the Impella as it's called in our vernacular, has been in practice for a decade. This trial has been trying to enroll patients for a decade. So, one can understand how hard it is to enroll, and congratulations to the investigators for their perseverance on this. And one of the important comments that you made was that in 50% of these patients, it was that the device was placed pre-PCI, which is a paradigm shift. I have a few questions for you, and I think you'd be the perfect person to answer because you're a critical care cardiologist as well as an interventionalist. Saras, when you are suspecting cardiogenic shock based on clinical presentation, index presentation, what makes you clinch that diagnosis other than just cool, clammy extremities and hypertension on clinical presentation? Is it lactate? Is it creatinine? Is it decrease in urine output? And, we're in the throes of STEMI here. So, I understand that time is of essence. And, this assessment needs to be made and the diagnosis needs to be determined before you are going to commit yourself to mechanical circulatory support. So I think it'll be helpful to listen your viewpoint as to how you clinch that diagnosis in an expeditious fashion before you commit to placing this device. And I'm going to bring right heart catheterization here as well, and the use of pulmonary artery pulsatility indexes. That's something that is required for you to clinch that diagnosis before you make the determination.
Yeah, that's a tremendous question, Ankur. That's really the holy grail of what we do in the cath lab, is make thoughtful, quick decisions, hoping that we are thinking about the right things and working on the right aspects while caring for an acutely ill patient. And the odds and stakes are that much more higher in patients with cardiogenic shock. So I'll tell you my approach. This is a conglomeration of all the approaches that I've learned from my teachers and mentors over the years, and kind of best practices that I've picked up in my own practice over the last few years, and trying to put it all together. So the few things that we have to be cautious in cardiogenic shock are: time is still of essence, but opening the artery is not the be all and end all of our existence in that space. So for all my STEMIs, including those with cardiogenic shock, I strongly resist the urge to go up with a guide catheter. So when I get access on this patient, I give off 10, 15, 20 cc's of blood for blabs. Often these patients with STEMIs come to the cath lab either directly to the lab or from the ED without having blood work drawn. So I give off blood so that we get a full hematological panel, metabolic panel. We get lactate, we get blood gases, etc. All that information that's going to come in by the time you're done with your diagnostic shots. After I get access, often radial, rarely femoral, once I'm up there, I like to have as much information at my disposal as I can without causing significant delays. To me, that involves this blood work that you just sent off, involves going up with a universal catheter. For me, it's a Tiger catheter. For others, it could be Jackie or something similar, is to get both coronaries without a guide and use the same catheter, dip into the ventricle and get an EDP. Often, if they've come to the lab, I've had either the fellow or myself put a probe on the patient and looked to get a basic assessment of the LV function, mitral regurgitation, and if there is any aortic stenosis that will fight you. So once you have all this information, so at this point you have a hemodynamic appreciation of their macrovascular hemodynamics with blood pressure, heart rates, etc. You have an understanding of their respiratory function. Look at their work of breathing. You've looked at their respiratory rate, saturations. Hopefully by now your I-stat blood gas is back. Maybe some renal function is back. Lactate is definitely back on the oximetry. And then you already have a central macrovascular assessment of the hemodynamics with an EDP. And you have an assessment of the EF. If there's any doubt, I will go with a pigtail and inject an LV gram. That's one of the last remaining indications to get an LV gram if I don't have an echo in a patient with STEMI. So all this takes maybe 5, 8, maybe 10 minutes, but it gives you all the information you need to make a thoughtful decision. And for me, I do not do a right heart cath at this point because it's a significant investment of vascular access and threading a catheter through the various chambers, which takes time, even more so if you're femoral, slightly lesser if you're brachial or IJ. But regardless, at that point, you have enough information to make a thoughtful decision. And for me, a rule of thumb has been if the LVEDP is greater than the LVEF, this patient is tethering or threatening to decompensate. It's a very crude, very basic, non-evidence-based measure. That's the best I have from personal experience in the cath lab. So at that point, I say, what sky stage? I mentally sky stage. And if there's C, D, and E, that's very obvious. It's sky stage B that worries me the most. Because these are the patients, you open the artery, then they start this negative spiral of myocardial ischemia, reperfusion injury, no reflow, and then you don't know what to do with them. So anywhere B through D, I stop, I upsize my access and get usually a mechanical circulatory support device in, which may involve either the impeller, which is my device of choice, or the balloon pump if it's a plus minus case, or rarely via ECMO if they're crashing. But you should have the ability to candidate for any of these devices. And the minute I see shock, my device always goes in before PCI, because I think Dr. Moeller, who presented the trial, had a beautiful statement, which I could not have said it better. He said, in the short run, in the next hour, the ventricular function is going to save the patient's life. In the long run, 10 years out, the open artery is going to save the patient's life. And to me, that's a very important guiding principle of how we care for shock patients.
Yeah, I know that these are excellent practical bedside teaching points. So thank you for going over your algorithm as to how you risk stratify these patients and make the decision upfront for deciding whether or not to go ahead and put the impeller device in before doing the primary PCI. Now let's go over the results, because the results are fascinating and something we need to discuss as well.
Absolutely. So their primary endpoint was a 6-month composite endpoint. So unlike 6 months or 180 days, unlike other studies that have largely looked at 30-day outcomes, they looked at all-cause mortality at 6 months for impeller CP plus standard of care versus standard of care alone. So the impeller CP arm had 45.8% mortality as against 58.5% in the standard of care arm. Again, clearly nearly half, 1 in 2 patients don't make it out alive at 6 months. Hazard ratio of 0.74 and a confidence interval of 0.55 to 0.99 and a significant p-value of 0.04. Then they looked at secondary outcomes. The secondary outcomes was composite at 6 months of escalation to additional MCS, either short or long term, cardiac transplantation, or death from any cause, was also positive with a hazard ratio of 0.72, 52.5% to 63.6%. They did have higher composite or worse safety endpoints with combination of severe bleeding, limb ischemia, hemolysis, device failure, and worsening AR. 24% versus 6%, hazard ratio of 4.74. So sepsis, renal replacement therapy, need for renal replacement therapy, and limb ischemia were all higher in the impeller arm. So in context, what this tells you is, despite having higher complications in the impeller CP arm, these patients still had a durable mortality benefit that lasted for the first 6 months, and the curves continue to diverge after the first 30 days. So other trials have looked at 30 days. These trials looked longer. While clinically, these patients often declare themselves in the first 24 to 48 hours. Good, high-quality healthcare delivery for these patients with or without mechanical circulatory support has durable, long-standing results for up to 6 months. And I do want to note that the upper bounds of the confidence interval for the primary outcome was 0.99, so almost approaching unity, which would mean that that would make the p-value insignificant, but it did not in this case. So if we choose to hang our hat on that hazard ratio upper bounds crossing 1 and p-value of less than 0.05, this trial is strictly positive. Now, if you look at the fact that these patients had higher complications, if we got better at complication mitigation, management, recognition, treatment, we could theoretically have an even more pronounced improvement in outcomes And that would make the trial even more strongly positive. So the fact that they had an outcome benefit despite the complications is an important finding to recognize.
Yeah, Saras, thanks for going over the results with us. First of all, I think this is congratulations are in order here, because this is the first trial across the spectrum of all shock trials, whether you consider IABP shock or ECLS shock. I'm talking in the mechanical circulatory support devices space. This is the first trial in years which has shown a mortality benefit. Now, the critics of the trial will say, it took 10 years, you have 360 patients, your p-value is 0.04, so barely made it. And as you said, the confidence interval is not straddling 1 for the hazard ratio. So, it strictly is a positive trial. Despite the adverse event rate, the number needed to treat is 8. The number needed to harm, if you consider, the adverse events which you mentioned, sepsis, need for renal replacement, and limb ischemia was 6. How would you respond to that comment from the critic? For a device like this, what would you say? What would you have to say to the critics of the trial?
Yeah, see, the Impella is a very polarizing device. I'll be honest with you. I think as an interventional and a critical care cardiologist, I've seen these patients do well and do poorly on both sides of the spectrum. So it's not a very straightforward thing. As an Achilles heel of many of the shock trials, as you recognize, is that these patients get tremendous care in the cardiac cath lab. They get tremendous treatment. They get lots of attention. They get all these, close monitoring with multiple personnel, and they go to the cardiac ICU. And then at that point, they say best protocols and standard of care or judgment, which essentially could mean anything. And so in the ICU, a cardinal principle is prevention of iatrogenic harm, early recognition of theoretical complications, and aggressive salvage or preventing complications from getting worse and snowballing and coming to a point of no return. And so this early recognition and the ability to detect and treat complications is critical in these patients. No single device, no single diagnostic tool, no single therapeutic tool acts in isolation in cardiogenic shock patients. It's a team sport with or without a cardiogenic shock team. You need to have protocols, you need to have policies in place, how you treat these patients, what to do, an algorithmic approach to these patients. And that is what saves lives. It is the multi-specialty expertise, involvement of best practices, and then codifying that so that can then be applied by whoever is staffing the CCU on a given day, independent of personal preferences and variations in practice. And I think subsequent trials which are coming, including RECOVER 4, I think their ability to protocolize shock care in the CCU and beyond is going to be critical to showing an improvement in outcomes.
Yeah, no, I couldn't agree with you more. I think systems of care is what is required, and I think centered around the institution of device therapy here, which now we have a positive trial. I think my personal take on this, and I was discussing this with one of the representatives from Abiomed, the manufacturers of the device that is in question here, is that I think two key things from my perspective. One is reduction in the sheath size for the device, which you will reduce limb ischemia and access site complications and bleeding. And then the other aspect of this, will be again standardized protocols to guide operators to consider antegrade perfusion. And I sort of wanted to discuss this with you, Saras. In your practice, do you do it ubiquitously across all your cases in which you put the device in, or how do you make the determination of establishing antegrade perfusion in these cases?
That's a great question. If it's via ECMO, I invariably almost always put in antegrade perfusion catheters. My traditional practice has been to put a 6-French braided sheet in the SFA in the antegrade direction, connected with a male-to-male connector to either the arterial limb of the ECMO or to the contralateral common femoral in case of Impella. In case of Impella, I am less ad hoc or upfront with my antegrade sheet. It's more ad hoc. what I do is typically, and this is advocated by Abiomed too, as you said, is two things. One is never leave the peel away sheath in, because that obviously is a big nidus for vascular complications. It may break, does break within common femorals and iliacs. And so always retract the peel away sheath, break it up, take it off, and then put in your repositioning sheath. I think there are many good principles with repositioning sheath. You hub it all the way till the white and blue transition point. You put a stack of gauze under it, kind of you may have it go in at that 30 to 45 degrees angle so that it's not pulled down flush against the skin, tenting up the artery. And then nowadays the repo sheath comes with a sidearm. So what I do is I do two things. I take a standard 035J and put it in the repo sheath all the way to the aortic root, and take a fluoro off or a cine of the aortic root with the wire in there and the impeller. So it tells you the depth of the impeller right away. So you know exactly how deep your impeller is, if the joint is at the space, at the level of the aortic valve, and if you're good. And then I pull the J wire out, I take a contrast syringe, half and half, and then I inject it under fluoro or cine. And then you look at distal perfusion. Obviously, by the time you're done with the case, your hemodynamics are stabilized, hopefully, your impeller level settings are stable, and your vasoactive medications are stable, which is what causes vasoconstriction. So at that point, if you take an injection and you don't see distal outflow, you know that if this patient goes to the CCU and they worsen, they will go up on your drips. The distal outflow will only get worse. At that point, I go ahead and put in an antegrade perfusion sheet below the repositioning sheet. If not, I send them to the CCU. We have a protocol where we check Dopplers at frequent intervals, making sure that there's posterior tibial and dorsalis pedis or popliteal are frequently checked and are documented. And if there is any compromise, we always, start looking at hemolytic markers, start looking at lactase, start looking at CKs, and making sure there's no acute compartment and things like that. So with impeller, I'm less aggressive with putting in all patients with a distal limb perfusion catheter, but my threshold's very low.
Yeah, excellent. Let's talk about relief HF. Context here for the listenership will be of advantage. What was the context, the hypothesis, and what the trial wanted to achieve here?
Yeah. Relief HF is a very interesting trial. It's a placebo-controlled, procedure placebo-controlled. So there was a sham procedure, randomized controlled trial that was conducted across North America, Europe, Israel, Australia, and New Zealand. So largely represented across the globe. 508 patients with heart failure, both with reduced and preserved ejection fraction, were randomized to an atrial shunt with a Ventura interatrial shunt device versus standard of care. So the pathobiology or the presumption is that patients with heart failure often have elevated left atrial filling pressures. These are often reflected into the pulmonary vascular tree with minimal exertion causing exercise intolerance, potentially causing them pulmonary edema, diuretic refractoriness, and there is no out because over time the pulmonary vascular tree remodels and then they develop pulmonary hypertension. And at that point, it becomes really difficult to treat these patients because now they have more than one reasons to be dyspneic amongst other things. So the hypothesis is that if you could offload the left atrial filling, high filling pressures into the right atrium through a iatrogenic interatrial shunt, then these patients will start to feel better by virtue of offloading this and taking it down the right system. So their primary outcome was a hierarchical composite outcome of death from any cause, heart transplant, LVAD, heart failure hospitalizations, worsening heart failure events, change in quality of life as measured by KCCQ, which is the Kansas City Cardiomyopathy Questionnaire. They used a novel, not so novel, but more commonly being used technique called the win ratio, where total wins versus total losses are counted and not all endpoints are equally important. There is a priority list of most important endpoint to least important endpoint, but at the same time, by making a composite endpoint, you have the ability to decrease your sample size and increase your N for outcomes. And so that was a primary hypothesis in the trial design. I'll wait to see what comments you have before I talk about the results.
Yeah, I think, a neat concept here. You're sort of trying to relieve, like you said, elevated left atrial pressure, which is a common finding in patients across the spectrum of all heart failure phenotypes, whether it's heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. I think the one aspect of the concept behind the procedure which fascinates me is, at least this is, I used to read atrial septostomy as sort of like a salvage procedure in patients with acute decompensated heart failure to relieve left atrial pressure. So I do think it sort of borrows itself from that philosophy of atrial septostomy, where you're trying to actually create an iatrogenic atrial septal defect. And in the same vein, there is this syndrome, right? Luton-Bucker syndrome. It's congenital atrial septal defect, which is complicated by mitral stenosis. But the concept is the same here, right? I sort of wanted to get that into the discussion to make sure that I'm understanding this correctly, the concept behind the device.
Correct. You're absolutely spot on. That's exactly the proposed mechanism. It's interesting how the results have panned out. So we'll talk about that, and I'd be curious for your thoughts, because I'm not a structural operator. So I'd be curious for your thoughts as a structural operator and as somebody who's an avid consumer of literature in that space. So like I said, their primary outcome was a win ratio with a composite of all the outcomes we talked about. They also looked at safety and looked at all cardiovascular events in the shunt group versus the non-shunt group. So for their primary outcomes, they had an unweighted win ratio of 0.89 with a confidence interval of 0.72 to 1.09. So crossing unity and therefore not significant. And the win ratio also for the weighted for the interim analysis was 0.86 with a confidence interval of 0.61 to 1.22 and a p-value of 0.20. Their safety outcomes was the risk of all cardiovascular events was 219 among the 114 patients in the shunt group and 222 in the 108 patients in the placebo group, with a relative risk ratio of 1.00. So absolutely on one with a p-value of nearly 0.96. What's interesting though is they had a pre-specified subgroup analysis. So at this point in totality, the trial is largely neutral. They had comparable efficacy and safety outcomes, which essentially says it's no worse to use this device, but it's no better. But in the subgroups, this is where it gets interesting. When they split patients by those with heart failure with reduced versus preserved ejection fraction. So they used a cutoff of 40% to define this. So, and they said that the unweighted win ratio in reduced ejection fraction was 1.21. But the annualized event rates in patients with the shunt and the placebo groups were 49 versus 88%. So a risk ratio of 0.55 and a p-value that is highly significant in HFrEF, whereas in HFpEF, their event rates were 60.2 versus 35.9. So the relative risk ratio of 1.68. So strongly opposite of HFpEF or HFrEF. So fundamentally, what this tells you is that HFpEF and HFrEF are absolutely two different pathologies. They have nothing in common except for the fact that these patients have congestion either intracardiac or throughout their non-cardiac vascular beds. But fundamentally, they're different pathologies, they're different populations, they have different comorbidities. There was a significant placebo effect. They were decreased. There were improved outcomes in both the sham arm and in the device arm. So there's definitely a signal towards improvement due to placebo effects. But after that, there was a signal towards significant improvement in hard outcomes in HFrEF, whereas a signal towards harm in HFpEF, which is an interesting concept. There are many postulations. So this was discussed extensively within my heart failure colleagues and their communities. But essentially, my learning has been that these patients are significantly different from the trial population of, say, reduced LAP2, which was another trial using a different device, but looking at similar concepts. But ultimately, it all hinges on the fact that how much pulmonary vascular remodeling have they had, and how much of that is affected by the higher flows that the pulmonary bed is going to see by virtue of this left to right new shunt that has been created. So the overall pulmonary vascular resistance is 2.1 Woods unit in this population, as against in reduced LAP2, where those who respondents versus non-responders, the cutoff was 1.7 Booth's unit. So the more adverse remodeling there is in your pulmonary vascular bed, the less likely that these patients will be successful with the left to right shunt, which makes a lot of sense. And then there's also this concept of things in HFrEF not working in HFrEF. So we have to be thoughtful. Should we actually have lumped these two populations together, or should we dedicate trials to one population versus the other, and understand that the bang for the buck in patients with HFpEF probably lies in addressing more of their comorbidities, such as atrial fibrillation, obesity, hypertension, diabetes, other things that contribute to HFpEF, rather than a primary cardiac target for intervention.
Yeah, interesting. To your comment on this being a procedure from a safety perspective, I think it's relatively straightforward. It's an inner atrial septal device. The orifice is 5 millimeters. I think it can expand to 6 millimeters. And it does that because of the discs which are on either side of the septum, which facilitate a venturi effect. And by facilitating venturi effect, it sort of expands the orifice at the septum itself. And then I think to your other comment on, pulmonary vascular resistance, which is a measure I report ubiquitously in my right heart catheterization reports, because I think it definitely pulmonologist who's referring you these patients. I think with the mean ratio, like you commented, of a little over 2 but less than 3 Wood units is suggestive or indicative of isolated postcapillary pulmonary hypertension. What that means is that this is all being driven by elevated left ventricular end diastolic pressure, which is sort of the final common pathway in both or across the spectrum of all heart failure phenotypes. But again, I think it's sort of very interesting, eye-opening, sort of needs more investigation to understand why the outcome or the win ratio, like you said, was different in the HFrEF or heart failure with reduced ejection fraction subgroup compared with the heart failure with preserved ejection fraction subgroup. I think the device maybe is not ready for prime time just yet. This is how I read into this. And certainly, I'm sure there's going to be more investigation looking at that pre-specified subgroup analysis and then cost-effective analysis. Again, sort of a programmatic approach needs to be determined if this device has to percolate clinical practice. That's how I see it. I don't know what do you think about that synopsis, Saras?
100%. I think as interventionalists, we should never underplay the risk of any invasive procedure. And the data need to absolutely convince us that this does offer something significantly over and above what medical therapy and lifestyle interventions can offer. So I 100% agree with you. I think it needs a little more nuance, a little more finesse, understanding the amounts of guideline. So importantly, this trial has not been published, as you know, it's only been presented. So it'd be important to look at the final publication when it does come out to understand how much the extent of guideline-directed medical therapy they were on, were they maxed out on their doses, where were they along their LVEF spectrums, what were their big picture plans. Was this, like you said earlier in this conversation, was this used as a palliation, or was this a step towards getting them through to a VAD transplant procedure in the near future, things like that. So I think there is more to this than just yes or no. I think heart failure is far more complex than many things we do in our practice, and I think this needs the appropriate respect and additional analyses.
Exactly. So, excellent. So, Saras, moving on, from cardiogenic shock, heart failure to now preventing our patients to go into heart failure. And that is the question on revascularizing or stenting lesions which are not obstructive, as we define obstructive in the common interventional vernacular. However, on angiographic findings or on intracoronary imaging findings, the operating interventionalist determines that this constitutes vulnerable plaque. which could be a vulnerable plaque rupture, plaque erosion, or a calcified nodule. So vulnerable plaque, non-obstructive disease, in the setting of an acute coronary syndrome, I take it, or just vulnerable plaque. And what you do with that, I'm talking about prevent. So why don't you tell the listenership about the inclusion criteria and what the investigators found, and then we can sort of delve into our own practice patterns and what we've encountered in our own respective practices.
Yeah, no, this is a phenomenal trial for interventional cardiology, kind of hitting the nail on the head of the holy grail of interventional cardiology, which is really preventative cardiology. So this was a multi-center open label trial. So it was between 2015 and 2021 at 15 centers, largely in the East and in New Zealand. So Japan, South Korea, Taiwan, and then New Zealand. With the population of which is slightly different from what you or I may see in our daily practice. So at about 1606 patients, 73% men, who presented either to angiography either for a stable ischemic heart disease or acute coronary syndrome. So in the former cohort, they may have gone significant non-invasive testing before they presented on the cath lab table. So they've had contact with cardiovascular services for a while. And then they looked at these patients, and then they said, which of these patients have plaque that does not meet obstructive criteria, which is either greater than 70% obstruction on angiography or FFR greater than or less than 0.8. So those were excluded. So only those plaque or those lesions that were not either physiologically or anatomically obstructive were included. And then they did intracoronary imaging on these plaque. The intracoronary imaging was used to define vulnerability. So vulnerability was defined as an MLA of less than 4 square millimeters on IVUS or OCT, a plaque burden of more than 70% by IVUS, not necessarily on angiography, or if you did NIRS, which is near infrared spectroscopy, looking at a lipid-rich plaque with a maximum lipid core burden of 4 millimeters on pullback, or a thin cap fibroatheroma, as defined by IVUS or OCT. So the reason this is important is because, as you know, Ankur, it's not the stable, calcified, thick-capped plaque that actually causes a STEMI. Often it is these thin-capped fibroatheromas, vulnerable plaques that are prone to plaque rupture, and then thrombosis, and then acute occlusion, which leads to a STEMI. So it's important that these be found and treated, because then theoretically, between that and lifestyle interventions and medical therapy, we could provide a significant change to the trajectory of these young or middle-aged patients who come in with STEMIs. Now, what they did is, so like I said, greater than 50% stenosis, negative FFR with these vulnerable plaque features, then they treated them with, or they randomized them to either standard of care, which at this time is medical therapy, or treat them with a mechanical therapy. Initially, this started as a trial of bioresorbable vascular scaffolds, BVS, and subsequently, because BVS fell out of favor over time, morphed into being a drug-eluting stent trial. So initially, it was bioresorbable scaffolds and then drug-eluting stents. They obviously excluded a good population of the patients that were confounded by other things like bypass graft patients, if they were previously stented in that target lesion, greater than 2 target lesions in the same vessel, heavily calcified or angulated lesions that would need a lot of preparation prior to deployment of the device, or bifurcation lesions that dedicatedly require 2-stent strategy. Their primary endpoint at 2 years was a composite of death from cardiovascular causes, target vessel MI, ischemia-driven target vessel revascularization, or hospitalization for unstable or progressive angina. And in these patients, those who received a PCI of the vulnerable plaque with optimal medical therapy, their rate was 0.4% at 2 years as compared to 3.4% in the optimal medical therapy arm alone, with a very strongly positive hazard ratio of 0.11 and a confidence interval of 0.03 to 0.36. These results held durability at 2 years, at 5 years, at 7 years, and longest term follow-up. Maximum follow-up was 7.9 years. And so these consistently held positivity at that time. Their deaths were very few, as you may expect from a trial with stable ischemic heart disease, given the excellent medical therapy that we've been using. So I'll stop here and ask you for your impressions first. I'll be happy to fill in with mine.
Yes. So, very well done trial. Flips interventional cardiology on its head, in my opinion, sort of becomes preventive interventional cardiology, like you eloquently mentioned at the beginning of the discussion of this particular trial. I think, I don't use spectroscopy in clinical practice. I never have. I have used OCT. I mostly use intravascular ultrasound. And there is chromatography on intravascular ultrasound, which sort of can give you a ballpark of vulnerability, when determining plaque vulnerability, very similar to spectroscopy, although I know spectroscopy is considered the gold standard. And then, I think OCT is really, really, in terms of its resolution and definition, can really differentiate thin cap fibrous atheroma from thick cap fibrous atheroma. And it's the thin cap fibrous atheroma which causes the problem and ruptures or erodes and causes MIs. I think in terms of delineating that routinely in clinical practice, I think credit to the investigators. They did a phenomenal job. The follow-up is fantastic. This is a markedly positive trial. I mean, this is no holds barred, a markedly positive trial. The question is, are we ready for this to be prime time, or do we want to see one more trial before we change our guidelines and we change how we deliver patient care? Before this was published, I'll tell you what I was doing in my practice. And, we've encountered this, when we are doing, angiograms on referred patients, whether it's, stable ischemic heart disease with recalcitrant angina on maximally tolerated anti-anginal therapy, or more so in the spectrum, for me at least, in the spectrum of acute coronary syndrome, whether it's unstable angina or whether it's non-ST elevation MI, and there is troponin. And then you would see vulnerable plaque, but it's non-obstructive. I've gone ahead and actually stented these patients, just because I've not been, I've been shy of leaving these lesions alone, because they just look too risky on angiogram and on imaging. So I think it was very reassuring for me to see the results of this trial sort of reinforced what I've been doing in clinical practice, when I've encountered such patients. Now, I haven't encountered them as commonly, or maybe we haven't looked as hard, I don't know. But I distinctly remember at least 2 or 3 cases where I was in a dilemma. And then, I went on to Twitter to see if others have encountered a similar scenario. There was discussion around this, debates and polls around this. And, I think when the trial came out and was presented at ACC, it was very reassuring. It sort of made intuitive sense to me. That's my take on it. What do you think about this, Saras?
100%. I agree with all of that. I have a couple of caveats. One is, I think it's just a function of technology. I think we need better intravascular tools or easier intravascular tools to detect vulnerable plaques than we currently have. Like you said, IVUS has a good surrogate. OCT has reasonable mechanisms of detection, but really it's all largely NIRS. And NIRS, again, I have not used it in clinical practice. I've seen it used for research purposes. It's not ready for prime time. So I think as we get better at using these tools, the better we will get at detecting these plaques. And now on the strength of these data, we'll be less apprehensive about stenting them. That being said, I do agree with you. When I have an ACS patient, no clear culprit, I often put IVUS down these 50% lesions that look worse on IVUS and they do an angiography. And oftentimes you will see ruptured plaque, a calcific nodule with erosion, things like that are high-risk features. So I think that is the first thing, is just convincing our community as a large to put down an intravascular imaging device down an artery that they're not convinced looks bad on angiography. If there's a high risk or clinical suspicion that this patient has had an ACS event or threatening to have an ACS event. So that's definitely the first thing, is